all. Thank you all so much for joining us this afternoon. We'll give it a minute for folks to join. All right, I guess we can get started. We have a lot to cover today and a lot of interesting discussions for you all. So again, thank you and welcome to everyone for joining our February 7th session of the Virtual Learning Collaborative, Maintaining a Longitudinal Database / Registry in NBS, made possible in partnership with the CDC Division of Viral Hepatitis. So my name is Zakia Grubbs, and I'm a manager here on the hepatitis team. Joining us for today's session are our presenters, Paula Shoup and Kate Goodin with the Tennessee Department of Health, and Sherri Davidson with the Alabama Department of Health, and our moderator, Noreen Kloc with the CDC Division of Viral Hepatitis. We also have some special guests today from CDC, Jennifer Johnson, NBS consultant, and Haley Vest, NBS consultant. They will be available during the session to answer any NBS questions that you may have. So feel free to type those in the chat so that way they can answer those as we go through the session. So for today's session, we will start with a presentation from Paula and Kate, followed by a presentation from Sherri Davidson and a moderated discussion with all of our presenters and Noreen. So feel free to use the chat to introduce yourselves and your jurisdictions, and if you all have any questions. So we will get started, and I will turn it over to Paula and Kate.
Thanks, Zakia. Okay, I'm going to attempt to share my screen. So give me just a moment. Can you see my screen? Okay, awesome. Hi, everyone. My name is Paula Shoup, and I'm an epidemiologist in the viral hepatitis program at the Tennessee Department of Health. And I'm going to be presenting today with Kate Goodin, who's the Director of Surveillance Systems and Informatics for TBH. And we're going to be presenting on our NBS longitudinal registry for hepatitis B and hepatitis C. Here are the list of topics that we're going to be covering. First, our actual foundation, which is our NBS registry, and then our reportable lapse and track conditions, workflow decision support, data cleaning and quality assurance, and our hepatitis C continuum of care. So first, we'll start with our actual NBS registry, and I'll hand it off to Kate.
Thanks, Paula. You can go on to the next slide. So I'm going to talk a little bit about background of NBS, and you do have some NBS experts here on the call with you, like they mentioned at the beginning, so maybe they'll answer any questions that I don't cover here. But NBS is used in the jurisdictions listed here, and then some other outlying territories, Mariana Islands, Guam, etc. But these are the CONUS states that are using NBS. Tennessee is one of them, and so is Alabama, that we'll be talking in a minute. And so this is a little specific for the tools and activities that are supported by NBS, but hopefully some of the lessons learned can give you an idea of what this looks like here in Tennessee. So next slide. So the way we have NBS set up is as a centralized reportable disease surveillance system. So I have an example of different categories of reportable disease here in Tennessee. And on the left-hand side, you can see all of the general program areas that are represented within NBS. And then we do have a few reportable conditions that are not included within NBS, which are on the right side with the red X over it. So birth defects, cancer, overdose, et cetera. But you can see that the robust way in which we use NBS is listed here, right? So we have our hepatitis, STIs, HIV, foodborne disease, vaccine preventable diseases, et cetera. And some environmental conditions like carbon monoxide poisoning. So the amount of people that are within the system is pretty extensive, and the different disease areas that they cover is also pretty extensive. So we were pretty specific in how we wanted to set up our hepatitis program area and our disease codes. You'll also see here the different disease codes that we do track in NBS, and then I have highlighted them separately for the ones that are nationally notifiable conditions and those that are state-based reportables. So NBS does allow you to configure the system for both sets of concepts. So not everything in NBS is nationally notifiable. Not all classifications of each disease are nationally notifiable, et cetera. And so the system allows you to configure that. So we're able to still use the registry for the robust way that we would like to for case management purposes by how we configure these disease codes and how we list our state reportable conditions. And again, those are listed here. Then Paul is going to go into that in a little bit. Next slide. We also configured our data access for hepatitis slightly differently than maybe some other jurisdictions might have chosen to, and this is also configurable at the state level. So we manage data access to this program area and all of them through role-based permissions, so the permissions that you're allowed and the functions you're allowed to complete. So maybe case investigation, creation, view only, editing only, all of the above. And then your jurisdiction. So we also have the ability to constrict access based on the jurisdiction that you are assigned, so that then field investigators can potentially only see cases that reside within their jurisdiction, that sort of thing. And then we configured our disease areas to allow hepatitis to be in our general communicable disease areas. So it does overlap with the majority of our other infectious disease oriented program areas. But we were able to restrict access through these role-based permissions and the jurisdictional permissions to ensure that our central office is the ones that are dealing with these disease areas. The other configuration is when we set up those disease codes that I highlighted on the previous slide, we created them as what I would maybe term a disease family, so that there's ability to switch between the different disease codes. So you probably noticed we had B and C, acute and chronic. So because they're configured in this disease family, our investigators and surveillance staff are able to switch between these disease codes and accurately classify cases as they gain more information and as the case progresses potentially through their continuum of care. Okay, next slide. So this is what the timeline looked like in Tennessee for using NBS for this purpose. And again, NBS staff, feel free to correct me if I'm wrong, but this is what we were able to put together as far as the timeline for how we put this together here in Tennessee. So there was a collaborative development nationally through the NBS supported group at CDC to develop a modern page template that started in January 2015. So this is a template that would be available to all NBS jurisdictions. It would kind of be a standard modern template that would meet all of our general surveillance needs for the reportable side of those conditions. That template was finalized in mid-2015, and then it was deployed as part of an NBS release in September 2015. So the reason I highlight that is because it does have some implications on the workload, both for our surveillance staff and our program area staff represented by Paula, because it requires a full deployment of the system of which the page is a part. It can be separated potentially if you are looking to kind of deploy this asynchronously to some of these releases, and I don't need to get into all those technical details, but this is when it went live here in Tennessee in September 2015. And again, you can see that there are some updated versions of the template that were available in subsequent releases in early 2017 and then late 2019. And in between 2017 and 2019, we were able to onboard for the hepatitis message mapping guide for those nationally notifiable conditions. That did take a significant effort. So you can see that we started that onboarding in October 2017 and then finished in July 2018. Next slide. So what does deployment really mean? So what does it mean and what effort does it take when we deploy the page and then when we deploy an NBS release? Initially, it requires us to review the page template, look to see if we at the state level want to customize that page template with additional questions, reordering questions, creating page rules. So creating like validations for individual questions or requirements on those questions. For the initial deployment, we did page porting from our legacy pages into this new format, which was a significant effort to ensure that all of the data was viewable in the front end and in our data systems in a consolidated way. And then for each deployment, we also review vocabularies associated with questions, value sets associated with questions, and many times those are managed by update scripts that are included either with the page template deployment or with the release deployments. And then some of those activities have to be completed when there are new significant changes to those page templates listed here. Okay, next slide. So what does it take to more maintain the system? So this doesn't necessarily reflect the full suite of activities that was completed when we initially deployed the system. But here for staffing at TDH in our informatics group, we have an NBS coordinator. We have 2 epidemiologists that support that, myself, the program manager, and then we have an informatics epidemiologist who more bridges the gap between our core informatics folks and our HIV, STI, and viral hepatitis program areas. So kind of straddling that SME side, which our programs maintain, and then the informatics staff that are in kind of our core program. The engagement across the spectrum of this deployment and development is pretty variable. So that's why I couldn't give you kind of concrete numbers of how many people actually it takes to maintain the registry alone, because it is so integrated with our surveillance system overall. But the effort does change over time. So for example, a deployment with page porting for a page, would require about 20% of the time for several months for the NBS coordinator and the NBS epidemiologist. Those are the staff that typically handle those tasks. MMG onboarding requires probably what I would estimate to be around 10% of our NBS epidemiologist time across each month, and this one took 9 months. And then Paula's going to go into the workflow decision support, but workflow decision support is a more continuous maintenance task. But the initial deployment was around 10% of staff time for the 3 EPIs listed above for about 3 months to develop those initial algorithms. And I'll turn it back over to you, Paula.
Thanks, Kate. Now I'm going to cover our reportable labs and track conditions in NBS. So here's our list of our reportable labs. So first of all, anything that's bolded in green have been added to the reportable lab list as of this year, which is very exciting. And all of our labs are actually housed in NBS. We don't have a black box for anything. So for hepatitis B, we only receive positive labs, and we have surface antigen, IgM, a total core antibody, little e antigen, hepatitis B DNA, surface antibody, total core antibody. And for hep C, we receive both positive and negative confirmatory assays and positive antibodies. And then just for those age 0 to 36 months, we now also receive negative hepatitis C antibodies. If any of those results are positive, labs are also supposed to report pregnancy status and any serological markers of hepatitis, such as bilirubin or ALT. And here's a list of our track conditions in NBS. We have our nationally notifiable conditions, acute and chronic hepatitis B, both probable and confirmed, acute and chronic hep C, probable and confirmed, and perinatal hepatitis C, confirmed only. So not only are all our investigations housed in NBS, but we're able to send our notifications through NBS, including our demographic and risk factor variables for our 2103 grant. And then we also have a set of local conditions that we don't send notifications for. And that includes possible hepatitis C reinfection or treatment failure, confirmed only, hepatitis C positive pregnant female, confirmed and probable, and perinatal hepatitis C, probable suspect and not a case. So how do we use NBS as a longitudinal case tracking? First of all, for each NBS record, an individual can only have 1 acute case and 1 chronic case for each condition. And then we look at cases over time, and as we receive additional labs, we'll go ahead and update that case status. I will note that once a case is confirmed, we don't bump that individual down if there's evidence that they've cleared their infection. Additionally, since we receive positive and negative confirmatory assays for hep C, we're able to track continuum of care for hep C, but since we only receive positive labs for hep B, we're unable to do continuum of care for that condition currently. Another metric that we look at over time is the number of people actually living in Tennessee with hepatitis C. And we came up with that number using all the lab results that are in NBS that have been reported from 2000 to 2021. And this includes people that have a positive antibody and no RNA result, or people whose last RNA result was positive. We then removed all individuals that we know are deceased or have moved out of the state. And the number that we came up with in 2021 was about 115,000 people that have been reported as having Hep C. And we're going to do our new 2022 number here in the next couple months. Now I'll talk about workflow decision support. So what is workflow decision support, or WDS, for jurisdictions that don't use NBS? As Kate said, it's essentially a feature within NBS that allows us to configure algorithms that will automatically process our incoming documents or labs. In the graphic here, I have an example for a Hep C lab. So if you follow the algorithm, it's either positive or negative. If we go down the negative route, it looks if it's an antibody or an RNA. If it's an antibody, it'll just mark the lab as reviewed. If it's an RNA result, it will look if there's already an existing chronic Hep C investigation. If there is, it will attach the lab to that investigation. If there's not, it'll go ahead and create a chronic, not a case. So really the foundation of WDS is electronic lab reporting. Prior to 2020, the state had 13 ELR partners. And then of course with COVID and the massive influx of labs that were being reported, there was a need to report those labs efficiently. Hence, the support and infrastructure was built out both on the state side and with many of our partners to be able to do electronic lab reporting. So from 2020, going from 13 lab partners, and then this slide has through 2022, there's 58 lab partners. That's additional 45 partners, and the informatics team is always onboarding additional facilities. So there's now the need there for those algorithms to help process that huge influx of labs. So again, COVID-19 really was the impetus for ELR and WDS, and that was the first program that had WDS development behind it, and then followed by MPOX. So once those conditions were onboarded in WDS, hepatitis B and hepatitis C were brought on as well to help process our labs. So how we use it in our program, for both B and C, the algorithms will automatically mark labs not meeting case definition as reviewed. For hepatitis C, we'll attach labs to existing cases or create probable investigations for newly reported cases. So WDS has been a huge help for our program, but it's also been a massive benefit to our regional and metro partners. As Kate said, we all use NBS throughout the state. So getting those hepatitis labs out of our lab queue so that's not clogging up that queue for our regional metro partners was a huge help for them. Additionally, it was also a huge boon to the vaccine preventable disease program in those hepatitis panels that include a Hep A result. So it's been majorly beneficial for us, our partners, and vaccine preventable diseases. And here's a list of the algorithms that have been developed to process those labs. There's 2 Hep A, 9 for Hep C, and 1 for Hep B. And those algorithms are updated as needed to better process results as we get new ELR partners, or if any of our partners change the way they're reporting the test or a result, then it requires updating of those algorithms. And so far, since we've rolled out WDS for our program, 134,000 labs have been processed. So as you can imagine, that's a huge help for us, and especially for our data entry team. And here's the general timeline for rolling out WDS for the hepatitis program. We started discussing the project in August of 2022 with the informatics team. We quickly realized we needed to bring in vaccine preventable diseases to process those hepatitis A labs. And then we rolled out our first algorithm at the beginning of 2023. And it was the algorithm that marked hepatitis C negative labs as reviewed. And then summer of last year, we rolled out the algorithm that attaches Hep C labs and creates investigations. And then our last major rollout was in October of 2023 when the algorithm started processing negative hepatitis B labs. And we've kind of been discussing creating a similar algorithm for Hep B that will attach labs and create investigations. But with the new 2024 case definition, we want to get comfortable with the definition first before we consider adding it to WDS. Now I'll cover some of the routine data cleaning and quality assurance that we do. So each week, any probable investigation that receives a new RNA positive or negative result, our data entry team will evaluate those cases to see if it needs to be made confirmed or not a case. One thing about WDS is that it does have a bit of a tendency to create duplicate records. So our data entry team will pull those records and deduplicate, so it's not actually too big of a burden for us. And then every month we'll review labs received from reporting facilities, and we'll look for potential drop-offs in reporting. If we do see anything strange, we'll report that to the informatics team to see if they might want to look into it further. And then every quarter, we pull death certificate data, and if anybody does have a new date of death, we'll add that to their investigation. We also update any missing or mismatched county, region, or state information. We merge duplicate records, and we also look for instances of hepatitis C seroconversion and reinfection. Okay, and last I'm going to cover our hepatitis C continuum of care. So in our program, we use a very strict definition for HCV reinfection. We consider someone to be a reinfection case if they have a positive RNA, followed by 2 negative RNAs at least 90 days apart, followed by another RNA positive. And these cases are housed in NBS, but again, we don't send notifications for them. We've been tracking them since 2021, and we've seen a bit of an increase last year. And I will note that 60 to 70% of these cases are from our state prisons. So they do a lot of testing and treatment. So it makes sense that we would see a lot of reinfections from that group. And here's our continuum of care cascade for hepatitis C. We follow CDC's proposed care cascade structure. And if you look here to the right-hand side, the last column, the cases classified as subsequently infected are housed in a separate REDCap project. And there's about 2,700 cases. And another group within our program is in the process of requesting records for all those cases and trying to get treatment data to analyze those cases to see if we might not want to update our current reinfection definition that's quite strict, because we suspect that there's more reinfections occurring, and we'd like to be able to classify those appropriately. And last, I just want to touch a bit on tracking treatment. NBS does have the ability to add, if somebody is on like Epclusa or Maybrett, you can add that to somebody's investigation, but we generally don't have that information for our cases. And the one caveat is with our Tennessee Department of Health regional partners. We have 59 hepatitis C treatment sites throughout the state, and our regional partners will report to us if an individual has initiated treatment. And once we know that, we'll be able to start monitoring for SVR for that individual using RNA results. And we calculate that SVR timeframe using the medication regimen that was reported, as well as their treatment start date, and we measure that against their RNA specimen collection dates. And that project is housed in a separate REDCap project. We don't currently use NBS for the treatment function that's there, but you could theoretically do that. That concludes our presentation. Thank you so much for listening, and Kate and I will be here if you have any questions.
Thank you so much, Paula and Kate. Now we're going to turn it over to Sherri to share a little bit about the work they're doing in Alabama.
Thank you. In Alabama, we're also an NBS state, as Kate mentioned. A lot of our processes and how we've gotten to our current state is very similar to Tennessee's. We are currently, so I'm also the state epidemiologist, so I'm not working in hepatitis day to day like most of you are. We are trying to fill a hepatitis epidemiologist position in our hepatitis program. We have a couple new, well, we have one new epidemiologist in our vaccine preventable disease program. And in Alabama, our hepatitis A, B, and C are not together. Hepatitis A and B are investigated by our vaccine preventable disease group, and our hepatitis C is housed within our HIV Bureau. In Alabama, the hepatitis B and hepatitis C negative results have been reportable since August of 2018. The volume has been manageable. It hasn't been overwhelming to our system, especially after it handled COVID. You know, we feel we can handle anything that can export to an Excel spreadsheet with less than 1 million records is small potatoes these days, it seems. So we have all of those results, although we did recently do some analysis on the results we're receiving, and we found that if a patient did not have a positive result on their hepatitis panel, we're not sure we're getting all the negatives. So we are following up with the hospitals and laboratories now to make sure that they understand that even if all the results are negative on the hepatitis panel, those should also be reported. I loved a lot of Tennessee's presentation. I was kind of fangirling it, taking pictures of different slides. And I'm very excited by the idea of developing new case investigations to identify the reinfections within the same hepatitis family. I really like that, and I think that's a great idea that Alabama can certainly benefit from. Right now, we have automated processing of our positive hepatitis C results that automatically create a chronic investigation if one does not already exist. And we are also having issues with that creating duplicates within NBS. Another issue that may be specific to NBS is that although we are able to provide everybody, all of our investigators across our program areas with view-only access to the hepatitis lab reports and the investigations, we are not able to do the same with the electronic clinical reports. I know most people call them electronic case reports. I am trying to move this forward, electronic clinical reports. But the NBS is not able to handle view-only access for electronic clinical reports at this time. And hopefully, since we have NBS folks on the team, I hope they're understanding the value of that and working on that for us to be able to better utilize the ECRs. There was one other thing I was going to mention. Oh, so processing them into the chronic. In Alabama, most of our acute hepatitis C and hepatitis B cases are identified through seroconversions. We don't receive a lot of physician reports, unfortunately. And for hepatitis C, we are only electronically processing the electronic laboratory reports to identify the acutes through the seroconversions and following up with any provider reports that we receive. As for the continuity of care, we're definitely not as far along as Tennessee is, but through all the snapshots I took, I'm sure we'll be having some meetings in the very near future to kind of utilize some of those tools for advancing as well. So that's my update. Renata, is there anything you would like to add?
I don't have anything to add unless there are questions. I'll take questions.
I've been looking in the chat. So maybe we could start with a question that came to you, Paula, that you've already answered in the chat, but maybe we could talk a little bit about it, which is, do you record your reinfection cases in NBS? And if so, how do you make sure they don't go through to CDC?
Yes, we only record them in NBS, and we did initially have that issue in 2021 that our team was so used to sending notifications, they just sent them through, but hopefully that didn't cause a problem on your end, because I don't know where the notifications went. But now we only have one individual on our data entry team processing those cases, and so I haven't noticed any more notifications showing up in the queues.
Yeah, and so then I mentioned the technical side of it. So in NBS, you can configure how your notifications work. So you can configure on the disease code level whether you can automatically send notifications using workflow decision support. You can require that a user click a button to send a notification, and then it will automatically go to CDC if you set the settings a certain way. And you can also tier that to say a user can send a notification, but it has to go to like a supervisor to review it and approve it. So there are different levels of configuration that you can set within NBS. If, for this example, we wanted to ensure that one specific disease never created a notification that went to CDC, we would have to create a separate disease code that doesn't allow notifications. So I outlined more details about that in the chat. If you have a lot of questions about it, or if you have follow-ups on that, just let us know. Paula, could you talk about how you identify labs with drop-offs in reporting?
So we just pull the actual labs every month, and then we'll look at if there's any changes in the additional facility in the individual facilities that seem out of the ordinary. Then we'll report that to Kate's team. And it is really difficult to track if it's a genuine drop or did a contract change. And we're working on a couple right now at a Memphis Shelby, and it is really difficult to drill down if it's a real issue or not.
Yeah, and when they contact us, we have to go through the same process, and it is a challenge just because there are so many, like Paula mentioned, a lot of our cases are coming from corrections, and those are typically done through testing contracts, and we've had several of those change, or they'll have temporary emergency contracts with other facilities, and so there's a lot more of the dynamics of who's testing that make it tricky for us to identify if there's been a drop-off as well, but we still follow up on them. We have a question. What is REDCap? Is this a local system? And then there's another question, but we can talk about that one first. So REDCap is a system that we do host locally, although it's available. It's not something we developed. So it's a software system that was developed by Vanderbilt University, but it's available for free. Technically, the code is available for free, but there are some costs associated with hosting and setting up your own local servers and all that sort of thing. But it's an application that hosts lots of different survey activities, data collection activities, data integration activities. So you can think about it as like a really souped up version of like Qualtrics or SurveyMonkey or something like that, but it has additional pieces into it. Like you can integrate it with texting applications to get survey responses. You can track content over time, et cetera. And so we use it extensively here at TDH for various different projects, not just with hepatitis. Here's your question, Paula. Also, the percentage of cured are pretty low. Are those all cured by DAA or some of them are naturally cured?
It's a great question. I didn't know it was a low percentage. They're about, I would say about 50% of our cases, like when we did that poll of the number of Tennesseans who are living with Hep C, that like 50 to like 53% look like they cleared or cured. So yeah, I'm not sure what other jurisdictions, what their percentage is on cured. And like I said in the last slide with the treatment that's happening at the health departments, we don't technically know if we see somebody clear, if it was from treatment or if they just cleared. So yeah, I'd be curious if other jurisdictions do have their treatment reportable or how they're tracking it.
That's similar in Alabama.
Oh, I'm sorry, Sherri.
Oh, no,
who's
no,
next?
please, Noreen. I was just going to say, in Alabama, we do not have a way to identify what takes them to zero, whether it's the treatment or just clearance. We know we do see a lot of reinfections, especially through monitoring our seroconversions. We see a lot of people bouncing back and becoming reinfected. And, you know, someone asked in the chat whether we track multiple infections, and I would like to better understand what CDC would prefer if, like Tennessee, we would only count someone as acute or chronic, especially for hepatitis C, only once, or if you count them once per year, or how that works.
just gonna come off mute, to say if any other jurisdictions would like to respond. But I also noticed that, Alan, you have a question, if you'd like to come off mute and give your expertise.
Noreen, I don't think I have expertise security, but I appreciate that. Y'all go ahead and answer that one first.
And then there was a clarification, I think, about whether we track reinfections as a separate disease code. So I don't know. I know that you replied back, Sherri, but I don't know if anybody wanted to say anything out loud.
This is Amelia in Utah. Kind of going back to where Paula was wondering about looking at negative labs and kind of in our care cascades, like we clump them together as cured, whether that's, but we don't know the detail whether it's actually like treatment, cure, or natural clearance. We sometimes can tell just looking at other labs that have been added, but like that's more of a manual process. So there's no way for us when we're like reporting on our clearance cascades to separate that at this time. Something else I was gonna say, but I don't remember what it was. So yeah, I hope that helps.
Thanks, Amelia. I think we have Ann Norman. Ann, is this something you'd like to speak to, or should we just take this down to respond in a future discussion?
Why don't we take this down to respond in a future discussion and we can give it a little bit more thought. But yeah, thank you for asking about the cascade.
Yeah, thank you so much, Ann. And just to let you know, if we don't have answers on the call, we'd like to be more thoughtful on some of these, and we have several meetings planned for the future, which I can touch on at the end of this presentation. And if it's not already planned for a topic, we would love to get your feedback on what you'd like to get more information on, and we can certainly either have a session or guidance in some form to help. So thank you all for what you've provided and asked so far. So I think this one would be good to respond later, but Alan, we didn't get to hear from you.
Noreen, I was just wondering, and this is maybe a question for Alabama or Tennessee and doesn't need to be gone into in a lot of detail. I was just wondering how you all get, if you have an entire message that is non-reportable, how you get that out of your queues to go to NBS, which may be a long, complicated thing, and that's fine if it takes longer to explain.
Yeah, I know that Jennifer put some comments in there, and I did just reply to your message as well. So we have the same filter that you kind of mentioned and that you and Jennifer were talking about. So our main filter is in Rhapsody. So we have a LOINC lookup table. So all incoming ELR messages hit against that. And if it's not on that table, it goes to a sync. So they never get into NBS. But we do have some non-reportable LOINCs on that table because we do want to bring them into NBS. And then there's a second location in NBS where you do the LOINC code mapping to program area or disease code, however we want to state it. And so we just then don't add them there and they go to our DRSA. So only our administrative informatics managerial staff have them there, and they can then mark them as non-reportable and have them marked as reviewed. And so they still show up in like the RDB and things like that, but they are not in like a DRR queue for an investigator, for example.
Great. Would anybody that placed questions or comments in chat if they would like to come off mute and restate either from your experiences and your jurisdiction or just to ask the question live, I'd appreciate it.
Hey, sorry, this is Allie Ertl, acting surveillance team lead. I was pulling the guidance from our viral hepatitis surveillance and case management guidance document to make sure I was copying and pasting appropriately. But essentially per the guidance, a new acute hepatitis C case is either an incident case that has not been previously reported or a case among someone previously reported as having hepatitis C who has laboratory evidence of a reinfection. Happy to follow up with more guidance, but we do cover reinfections quite extensively in our surveillance guidance document, so that would be a good resource to reference as well. Thank you.
There was a question in the chat. One was, when was negative RNA made reportable in Tennessee, and is it reportable in Tennessee? So maybe you want to talk about that a little bit, Paula.
Yes, and it is reportable in Tennessee, which allows us to do our reinfections and our HCV continuum of care. And I believe it was 2016, right, Kate? Yeah.
Yeah.
So I'd also like to mention to the audience this, even though we have this topic focused on NBS, we're interested in other surveillance systems and how you might be setting up your registry. There could be a lot to learn that we can all exchange ideas and possibly come up with the best of all. So if anybody would like to talk about how their registry was built, either within their surveillance system, a standalone system, and how you're managing the large volume of negative results, how you're automatically classifying cases, anything along that would be interesting to hear.
Hey, this is Amelia. I was trying to see if there was a hand raise button on here, but I can't find it. So I'm sorry for interrupting, or if I cut anyone off. But I'm curious if anyone is using EpiTracks, because we are, but I've really been hearing that it's starting to be implemented in other jurisdictions. And so I guess maybe more, this is also mentioned that if you are using EpiTracks for your hepatitis surveillance, we've been using it for several years and we're honestly really lucky to have such a robust system, but I'd be happy to talk about it if others are actually using that as a system.
Thanks, Amelia. That's a good question. And I know we have other EpiTracks users. If anybody'd like to comment now, or if you'd like to put in chat that would be a really good discussion for a future meeting, we could add that to our list. I did see another question that was responded. Adam asked, Paula, in Tennessee, would you mind sharing your parameters to classify a cleared infection and reinfection, example number of days between positive and negative RNA results? Paula, do you want to talk about that?
Sure. There first has to be 2 RNA positives. And then between those 2 RNA positives, there has to be 2 RNA negatives at least 90 days apart.
Thanks, Paul. That's what I was asking. We debated a lot on our definition for reinfection and clearance on the number of RNAs and days in between. So I was just curious what you were using.
And hopefully our continuum of care results will provide more support and evidence of which, I don't know, what days we should be using. And some people only have 1 in between and huge viral loads once they do have their RNA positives, and there's those that have a change in genotype. So hopefully we'll have more data here soon as we make progress on our COC project.
Yeah, if it's any consolation, we also use 90 days and just a single negative RNA versus 2. But 90 days is also our parameter.
Adam and Paula, I'm trying to keep up with our questions and comments.
Hi, Noreen, it was a little low. I didn't hear what you said.
Oh, I'm sorry. Can you hear me now? I just wanted to say I'm trying to keep up with the comments in chat. Or if there's any new questions, I don't see any new questions, but if anybody would like to come off mute and ask, just in case I missed it, I'd appreciate that. So hearing none for the moment, go on, Rachel, and then I'll ask my questions next.
Sorry. A long time ago, CDC recommended that we talk to Tennessee about NBS because we were and continue to be struggling with the volume of test results that we have in California. And my recollection from that conversation, which admittedly was probably a couple years ago, is a lot of this work is manual. Or I don't know if that's not a correct interpretation anymore, but I think the question I had in the chat was like, would it be possible to use NBS without manual review, without having to press buttons and do things for each individual patient record? Because we have millions and millions of records in California in our Hep C registry. And so everything we do, we have to build it in a way that it doesn't require manual review. And that rules out, honestly, a lot of different options for us. So just curious, like, is there a world in which NBS could be used without having to manually review records?
In Alabama, that's how we're working it right now with our chronic hepatitis C, where it's automatically processed, opens the investigation, fills in some of the fields, assigns the case status, and creates the notification without being touched.
Yeah, and maybe
what do you do for deduplication?
Yeah, that is, right now we're kind of looking at it after the year when we're looking through them to make sure there aren't any duplicates for that year. But I think we do want to enhance that and maybe even follow Tennessee's pathway with, one per person.
I'll just say for Tennessee, and Paula can echo, but we do also do 100% automated reporting for our COVID cases in NBS. So just like how Sherri mentioned, they're doing for hepatitis for our COVID volume here in Tennessee, even since early on in the reporting process, that has been 100% automated all through the notification process. The only thing, like we both just highlighted, is the deduplication of potential cases. It's just not that, I don't think, I don't want to say sophisticated, but sensitive maybe, or specific about how it creates duplicate cases in NBS. So there's just some noise there. I don't know if you guys have evaluated it, Paula, but it seems like the case classification portion, the filling out fields portion, like all of that seems to be as correct as it needs to be. It's really like, are you willing to accept the noise of some potential duplicate cases?
And this is Jennifer with the NBS team. I know Sherri or Kate, you can speak to this as well, but the system does have the ability to check to see if the patient already has an investigation for that condition. And if so, just associate the incoming lab to the investigation that already exists. But I think, as Kate alluded to, it doesn't catch everything, especially if there's not a good match. And the system isn't able to determine that it's the same patient because, key information was different for some reason. It does filter out some of that, but inevitably there are going to be some things that slip through the cracks.
I'd like to ask if any of the states are using batch processing for deduplication, either within data sets or across data sets for matching.
In California, I'm not the data analyst, but we are rebuilding our registry using the R deduplication package. I don't know if any of our EPIs can speak to that that are on the line.
Hi, I don't know if, I think it was Monique was, had their hand raised earlier, or Monica. I don't know if you still wanted to ask your question.
Yeah, no, I just wanted to comment for Indiana. We are doing a lot of batch updates. There's a lot of stuff that I'll identify through the back end and then give a set of cases and variables to our IT team that they'll just then, update 1,000 cases for me. And if I need them to, they can flip the flag. So it'll send the notifications to CDC. So I did want to comment on that for NBS. And for deduplication for us, we've been working on a program in R that we've created that we've been working to match patients against themselves basically within the system. We create those higher percentage matches and then go through that and identify those actual patients and merge them, and then we'll work on deduplicating the cases after that. So.
Rachel, do you know if anybody from your team, any of your EPIs would like to talk about your routines? We've had a chance to hear about it, and it's pretty in-depth. But if not today, maybe another time. Would anybody like to in California talk about it?
I think maybe once we're done rebuilding our registry, we could do a presentation on a future call.
That would be wonderful. It sounds like from several of the discussion threads we've had that there could be a lot of very particular in-depth technical topics. And I wonder if people can just put in chat like what you'd like to hear more of in depth from other jurisdictions. And then we can also, from the CDC side, provide guidance where it's possible from us as well. But if you want to continue to add that context to the chat, I'll try to get a copy of this before we end the meeting. That would be very helpful. And we're getting close to the end, so I'll just comment now that, and I welcome continued conversations and dialogue during this meeting, but I just wanted to make sure I had a chance to announce that for the national meeting coming up in April, we do have 2 surveillance outbreaks, not outbreak, but the special sessions, breakout sessions, and one will be on establishing negative hepatitis C RNA lab reporting, and a second on building longitudinal surveillance registries for chronic hepatitis C and developing clearance cascades. And then the NBS team will also be hosting a meeting on March 13th. And I wonder if, Jennifer, if you don't mind giving a little plug about your meeting.
Hi, Noreen. Thank you. Yes, so the NBS community has a weekly subject matter expert call, and we're going to be dedicating an entire one of the sessions. It happens every Wednesday at 3 o'clock Eastern to viral hepatitis and workflow decision support. And there are several states, including some that have talked here today, who will be presenting what they want to do. And I think we're also going to be flowing through what we've been informed that states need to do with viral hepatitis, and walking through what you can and cannot do today using workflow decision support to help identify any gaps and maybe workarounds for some of the things that may or may not be able to be done in WDS. So that meeting, any of the NBS jurisdictions, your NBS coordinators should have access information for that. If you want to contact them, if you're a program person to join us. And if you don't have that access information, feel free to reach out to Noreen and we can get you connected up. It's also open to non-NBS jurisdictions. So if you would want to join us and share ideas, I'm sure we could learn from one another. So don't feel like you can't join a discussion like that if you are not an NBS jurisdiction. We welcome everyone. So thank you, Noreen.
Thank you, Jennifer. So please, if your EpiTrax custom system, STC, you're welcome to join. I also wanted to mention that with this session, I thought it was very informative that there is potential to do a part 2 with topics. So we have multiple opportunities with various forums to kind of dig a little deeper, either on the technical side or just providing more guidance around some of these topics. Does anybody have anything that they'd like to add in the last few minutes? Either feedback or another question? We have a few minutes left.
I had a quick question. In the chat, someone had asked a question about how RNAs that are below detectable, I can't find the comment, how it's being interpreted, but I wasn't sure if someone had mentioned the interpreted as a negative, but I wasn't sure if it was a less than 15, just like no comments, or a less than 15 detected below the threshold limit.
I think it's usually when it just says less than 15 and there's no detected versus non-detected, like there's no qualitative result. It's just we've gone back and forth over the years about how to interpret those based on the APHL guidance.
Okay, yeah, I agree with that then.
This is Lauren in Pennsylvania. I just have a quick question about that a little bit further. Wondering if anyone has gone to like informatics folks at labs to ask if they're inputting those qualitative results, if they're sort of interpreting the less thans in that way, or if it is truly coming from the actual laboratorians, if that makes sense.
So I don't know that we have only done hepatitis results, but my team is also the one that onboards ELR for Tennessee. And I will say that when we do onboarding, we typically have representatives from both the lab and the interface informatics development folks. That's not always the case for some of these third-party data brokers, but for the facilities we directly onboard, we try to do both, and we extensively work on their vocabulary sheets to ensure that we understand their lower limits of detection, their interpretation results, and we go through that conversation with them to ensure that what is being sent is correct. I would say that the majority of the time, the interface is just passing what is received from whomever is operating their LIMS system. They could still have some automated processes that create some of those values, so like workflow decision support within their LIMS system potentially, but it's laboratorians who are doing that portion of it, and the interface staff are typically just passing that on. At least that's what my experience has been working with providers to onboard them for ELR. That really it's the interface folks are just repeating data that is received to them. If they do interpret something, it's directly in combination with the lab staff to decide what that is. And then again, it's hard coded. They're not adding their own interpretation in my experience.
Thank you. That's helpful.
All right.
Sorry, just one quick comment. I think the issue is that some tests are not FDA approved to provide a qualitative result.
All right, well, thank you all so much. I don't know if we had any last minute questions or anything. If y'all had any, but I wanted to thank so much for our presenters, for our CDC folks, for joining us today and answering questions and letting us know about things that are coming up soon. So yeah, thank you. This was amazing. And that chat was kind of insane. And hopefully we can parse through it and make sure we didn't miss any questions from you all. But always feel free to reach out to us, reach out to your CDC folks if y'all have any other questions. And with that, I will say thank you. And we have our next VLC session on February 21st, and we will see you all then. So thank you all so much.
Thank you all. I appreciate the session, the conversation.